see the superior semicircular canal, the posterior semicircular canal, the common crus, IAC, aqueduct, facial nerve, stericate ganglion, mastoidea cells, medius incus, significant facial nerve, editors, and the famous high-stream appearance of the ossicles, the vestibules, the stapes footplate, sinus tympani and facial nerve, modiolus, pyramid, promontory, carotid artery, jugal bulb, and sigmoid sinus. So, if I read my axial scans, I am coming from medial to lateral. So, this is the first slide where I am in the medialmost part of the brain. I am quite inside, which is very well visible with the sphenoid sinus in view. As I see, this is the petrous apex, which is the deepest part of the temporal bone. As I move further, I see the first two dots. This is the appearance of the semicircular canal, the superior semicircular canal. As I move further, these dots get wide apart, so these are the first structure that appears as I go from medial to lateral. The first dots that appear, these are my superior semicircular canals. As I go further, I can see that at 90 degrees, there is appearance of another canal, which is my posterior semicircular canal, and here is the appearance of the lateral semicircular canal. So this area will be my crus scanning area. This is my superior canal, this is my posterior canal, and this is the appearance of my lateral canal. So this will be my crus coming area. I hope everybody is clear by now. And this is the appearance of internal auditory canal. The landmark which I usually use in my scans is the appearance of meatus in the middle layer and corresponds to the appearance of the internal auditory canal in the inner layer. If this is the internal auditory canal, then posterior is the development of the vestibule area, and immediately this small thing is the cochlear bud. So the facial is visiting from here, and genicular ganglion will be somewhere here. So if this is my medius in the middle layer, the internal auditory canal is the structure that will be corresponding on the axial scans in the internal layer. This signet ring shape is the lateral, which is marking the point of the vestibule, and as the cochlear part is anterior to the internal auditory canal, so this will be my cochlear bud area, and this will be my genicular ganglion. This possibly will be an area of vestibular aqueduct. As I move further, I see that there is a typical broccoli appearance which we call, this is the development of cochlea, and this is the IAC, and this point is my nucleus. This is very, very important. All the nerves are entering the cochlea here. So this is my nucleus, this is IAC, this is cochlea, and these two dots, these are my incus and stapes, the reticular process. So this is the incus joint area. This is very, very important. As I go further, I see that tympanic segmental scan is not very clear though, but this was my broccoli appearance, this is my IAC, this is my signet ring lateral canal, and these are my ossicles, two dots. So this is the area of the facial nerve. Important to note, this is the tympanic segment of the facial nerve is beginning to come, and we see that the facial segment, the soft tissue density, is covered by a bony canal. So facial is not recent, and nowhere it is above or lateral to the signet ring. As I move further, I again trace my facial nerve. Facial is again coming as I am moving laterally, and again it is nowhere lateral to my signet ring, that is lateral semicircular canal. These are again my joints, and as I move further towards the mastoid segment, we see this soft tissue density, which is again the facial nerve, and it is nowhere above the labyrinth. So this is very, very important point as we are dissecting or as we are decompressing the facial nerve or we are doing the mastoid surgeries. Till the time we are lateral to our lateral semicircular canal, most possibly, if there is no anomaly, we will not be injuring our facial nerve. As I go further in the axial scans, I come more laterally. I will be able to see the proper signet ring of the lateral semicircular canal, and this is the appearance of the smiley sign of the cochlea, and this point is my round window. This is the smiley sign of the cochlea, and this is my round window. This will be the round window of my brain, and this will be the round window, and its anatomy is very important for the surgeons who are doing cochlear implant. As I move further, I further see the the round window, and this is the subsequent appearances of the wings of the cochlea. This is the development of the sinus tympani muscle. And as I move further, I see that this is my cochlea, this is my round window, this area is a W which is forming here. This is the pyramid which is attending to the stapedius tendon, and this is my sinus tympani which is an infrapyramidal recess, and this will be my area of facial recess which is a suprapyramidal recess. So this is the cochlea and this will be my round window, and this is my pyramid. This will be my infrapyramidal recess which is sinus tympani, and this is my facial recess. As I move further, I see the carotid. The carotid is coming into the view, and further down, the carotid is getting narrowed down, and this is my tympanic. This structure is my tympanic membrane, and this structure is my external auditory canal. This is the jugular bulb which is coming into the picture, and there is a bone between these two, and when it is eroded, it is known as flap sign, which is very important and pathognomic in cases of globus tumor. This is the appearance of mastoid antron, and this will be the area of my stylomastoid foramen where the facial rotator sit. For the coronal cuts, the checklist should be the dural plate, the semicircular canal, the sputum, and the foot plate. Dural plate and sputum are possibly the most important landmarks which we do not see in the axial cuts, and we should look for in the coronal cuts checklist. Now, if this is again I am coming from deep inside to out. This is again the appearance of the two dots is this first structure. These are the openings of my semicircular canals. As I go further, the openings get wider, and here I can see the appearance of vestibule with the proper appearance of canals on the coronal section. This is the superior, this is the appearance of lateral, and this is the posterior. This is again a very good formation. I can see my superior canal, my posterior canal. If this bone is eroded, then we can say that it is a superior semicircular canal license. So to see this area is very important when a patient of vertigo and osteoporosia comes to us. And this is the appearance of my lateral semicircular canal. This dot is possibly a dot of facial nerve. This is again the appearance of this semicircular canals. This is my first ossicle, that is my radius, and this bone is the sputum on the lateral wall, and its erosion is the first sign of the involvement of Pruitt space or cholesteatoma. This is the cochlea, and this is my tympanic membrane which is attached to the radius. As I go further, I see this picture very clear that this is my TM and this is my radius, and this is the area of stylomastoid foramen which is clearly seen in this area. This is my inferior joint which I am able to appreciate, and these are the two dots which are just before the cochlea. These are the two dots of facial nerve. If bone is not present here, then facial can be lessened in the tympanic segment. So it is very important to see these two dots of the facial nerve. In the section where I am able to appreciate two more things, one is the cochlea and other is the inferior joint. This is my incus, and this will be the area of my oval window. This will be the area of my oval window, and this again will be the attic, and this whole area will be the tegmen on the dural plate, and its erosion in all of the coronal sections is very important to see if the dural plate is eroded or not, or if the disease is going inside through the dural plate. Thank you very much. This was the basics of normal